And I'll simply echo the statements of the other presenters today that there's no question that the SGR is broken and that we're in dire straits. We're really grateful to have this opportunity to present before you because I'm an example of a small business person. I'm a general surgeon. I'm in a town of around 60,000. There's 7 of us in town that take general surgery call. And it's important for the members to understand that we all are in our own businesses. We have to hire employees. We have to buy from other small businesses in our community. And so what happens to us affects all of the small businesses, and vice versa, what affects small businesses in our community affects us. Now, it's interesting that the College of Surgeons is composed of many different surgical specialties, but I'm going to refine and constrain my comments to general surgery, which is about 40% of all of our membership. It turns out that of the general surgeons, around 78% are in private practice, so it's a high percentage of those are small business people, and of those, around 40% or so derive their income from Medicare. So Medicare is one of our larger payers, and therefore what happens to Medicare is very, very important. The average general surgeon has, in a practice of around 4 to 5 people, has around 15 employees, and they have a payroll of around 130,000. So it's like a regular business. And part of our concern is that we don't know when to depend upon the next pay cut. We can't make our budget, we can't project our expenses, not knowing what was going to happen with the SGR. Now, the other thing that kind of sets surgeons apart from other physicians to some extent is the fact that we're paid on a global payment scale. We're paid at 90 days global payment for most of our major surgical procedures. And major surgical procedures really have not risen much in the last 5 to 10 years. We're at about a 3% growth rate. But our payment is a lump sum payment for everything we deliver in 90 days. Now, for many different reasons, payment being one of them, we're running out of general surgeons. And the general surgeon, as you very well may know, is the surgeon that's in charge in your hospital, your local hospital, for emergent surgery and trauma surgery. There are only 1,000 general surgeons that come out of residency every year, and of those general surgeons, only around 300 elect to go into true general surgery. Others subspecialize, go into laparoscopic surgery and other things. So the number that the college sees of general surgeons being available to be emergent surgeons and trauma surgeons is dropping dramatically. When you look at the big numbers, HRSA had a study out just this year in October of 2006. There are only 21,000 active practicing general surgeons in America. Now that's a small number, and when you put on top of that the drop in the number of surgeons we project, it's really going to become critical to the local hospitals for trauma care and emergent care. As small business people, though, however, the general surgeon has also an effect on the local hospital. If, as we've heard, if a surgeon retires and a physician retires, oftentimes we can't find replacements to fill in our slot. For a general surgeon, if they retire, the hospital has roughly 18 months, if that's the only general surgeon, to replace that surgeon, or the hospital will dramatically reduce its services or have to close. So it has an impact not just on the local physician practice, but also the small business practices that rely upon that hospital. We've seen a drop in our physicians that go into private practice that are in office-based practice by 18% in the last 5 years. So it's not just a hypothetical thing. We're actually seeing that in general surgery today. Well, I've gone a long time about this. What evidence do we have that this really is occurring? There's 2 studies I have in the written comments, but I'll just highlight those. In North Carolina, from 95 to 2005, 47 North Carolina counties experienced a decline in the number of general surgeons, and 4 completely lost all general surgery coverage. I was intrigued by that, so I looked at the data from Arkansas, and between 97 and 2004, 12 Arkansas counties experienced the same decline. We have 21 counties that have no general surgeon, and of the 7 counties that lost general surgeons, 2 of the hospitals closed, and 5 of the hospitals had to decrease their services dramatically. So this has an impact not just on the surgeons, but on the community itself. Our proposal, and one of the things we're trying to discuss with others, we and the American Osteopathic Association have an alternative proposal for the SGR, which is broken, and that's the service category growth rate. And that's a proposal to divide the services we have into 6 unique service categories, not by surgical or medical specialties, but by the type of practice or service that they are. Preventative care and primary care, other evaluation management services, major procedures, which involves what we do, minor procedures, imaging services, and then diagnostic tests, etc. We feel that this will allow Congress and the administration to better control the management of those individual services. It's much like operating with a scalpel instead of a broad axe. Right now we just have a large axe to perform surgery with because one cut takes care of everyone. We propose having a much more refined solution to that. So in conclusion, I think we can propose that the current SGR fix itself, it needs to be fixed immediately. We agree with everyone here, and we will ask for also attention to some alternatives such as the separate category growth rate. And on behalf of the American College of Surgeons, I really appreciate y'all's time and effort today.